Dr. Steve Wexner. I'm at Cleveland Clinic, Florida as Director of the Digestive Disease Center and Chair of the Department of Colorectal Surgery. I routinely use ICG in left-sided anastomoses, so any anastomosis between the colon and the rectum, the colon and the anus, the small bowel and the rectum, I would routinely use it. I selectively use ICG for other anastomoses like ileoanal anastomoses, ileostomy closures, right hemicolectomies. I use ICG because I think that it improves patient safety based on the data that we have from our own published Pillar 2 trial, as well as subsequently from several publications in which we show very impressively low leak rates, anastomotic leak rates, using ICG. I think it's important to optimize patient safety in every single procedure. Certainly there are other adjuncts that we do technically for anastomoses to ensure that they're tension-free and well vascularized, but having the additional perfusion assessment, which we know from our Pillar 2 trial, the margin can be changed in about 6% of patients, and that 6% change can be a difference in a leak rate of perhaps 3 or 4% to perhaps 9 or 10%, which is highly significant. So I believe that ICG should be used to optimize patient safety. I think that ICG is becoming a standard of care. I'd like to see it as standard of care. I don't believe that it is yet, and I think that is up to us to educate people as to the potential benefits of ICG and to allow people exposure as to how to use it, and then for our colleagues in industry to ensure that it's readily available on the market with every type of optical solution to surgery, and then our hospital administrators to ensure that it's available to us as surgeons, as well as for the public to become aware of the potential benefits of ICG. The advantages of the ISFGS are that we get to interact not only with surgeons from a variety of disciplines. Most of the congresses we attend tend to be limited to 1 or 2 specialties, a bit myopic. This society includes people from endocrine surgery, plastic surgery, cardiothoracic surgery, general and bariatric surgery, colorectal surgery, and so on. So it's a tremendous amount of cross-pollination and getting good ideas from other people. In addition, it is one of the very few opportunities in my 32 years working at Cleveland Clinic to be able to sit around a table with industry, and as we pose potential problems, they can start to think about potential solutions. So we have a dialogue, and it is inclusive. So ISFGS tries to have everybody who's in this space of fluorescence imaging and ICG around the table with us, so that presumably just as we as surgeons learn from each other, they too, as our industry colleagues, can learn from each other. So that's a very, very unique dynamic forum. I think the next thing for ISFGS is going to be going beyond educating ourselves and educating the rest of the surgical world and the industry world and patients and hospital administrators and payers as to benefits of ICG and fluorescence imaging at large. Part of that is going to be through the Delphi process that Drs. Rosenthal and Dipp have initiated to allow us to find out what are best practices, what are standards, on what do we agree or disagree, what research is needed, and then to put those results in the peer-reviewed literature in public domains that other people are aware of them. The second component is education, having programs such as one that we'll be having in February in Jerusalem, where we're going to be inviting people who may not use ICG and may not be aware of fluorescence imaging to learn what the society has put together for them. And then the other one will be, of course, having some things live on the web as Drs. Rosenthal and Dipp are organizing, so that we can educate people who won't necessarily read those articles in journals and won't necessarily come to our individual workshops and meetings, but can access material online.